Great stuff. All right. Well, good morning, everyone. Really good to see you. And I see Kim, Leanne, Sharon, Isabel, Sabrine, Jag. Lovely to see you too as well. It's been a little while, but good to see you on the call as well.
Hi, Jay. Hi, everyone.
Hi. So thank you for joining this session today. So today's training session is really an accompanying piece of guidance, I guess, to the written guidance that was provided on Friday, which was in response to the DCJ sector, particularly some of the smaller, particularly community organisations, asking for a bit of additional support around the development of their COVID management plans, recognising that many providers already have got this in hand, but there has been that sort of request for some sort of clarity about how to develop this guidance. So that's what today is all about. So I'd like to start by acknowledging the traditional owners of the lands that we are meeting on, or the lands that we're meeting on today across Australia. We'd like to pay our respects to elders past, present, emerging. We'd also like to pay our respects to all Aboriginal and Torres Strait Islander people who are living in the communities that our services are supporting, and to any Aboriginal or Torres Strait Islander people on the call. And it's very interesting. I had a very good discussion with Lisa Sampson yesterday from the Aboriginal Community Housing Industry Association, and she was making the point that, of course, this is a very live issue for Aboriginal and Torres Strait Islander communities now. So there's been in New South Wales, there's been 12 Aboriginal and Torres Strait Islander people have passed away since June, since borders have started to reopen. So we know that we have lower vaccination rates in our Aboriginal and Torres Strait Islander communities, and so this is really being felt quite heavily in those communities. So this work that we're doing to try and help preparedness around COVID is particularly important for those communities. Okay, so just do a couple of housekeeping things and then we'll do some introductions. So as I said before, we've got quite a small group today, so which is great. Means we can have like a nice free-flowing conversation. So what I'd say is just chip in with any questions at any point during the session. We've got lots of opportunities to just get a good dialogue going. It's great if you can turn your cameras on. So that's we prefer it if you do. It's lovely to keep the conversation going. And I think everyone's already gone on mute. So yeah, thanks for that. But just come off mute at any point, ask any questions. And yeah, and we encourage you to just try and turn off what other things you've got going on, so we can concentrate on the session really. So that's just a bit of housekeeping stuff. We actually, because we've got a small group, we're not going to use breakout groups today, but we have got the chat function. So we found it really helpful in the previous 3 sessions that we've run to just pop any questions that come to mind at any point in the chat. And I see Miriam's just joined. Miriam, welcome to the training session this morning. Good to have you on board. Okay, so we'll do some introductions in just a moment. After that, Mika and I are going to provide a bit of an overview of the guidance, and Daniel from Justice Connect will also provide an overview of some of the key issues from a legal perspective. And Daniel's also here on hand to ask any questions of a legal nature that might come up during the session. And then we're going to look at some of the key considerations for the workers and clients that are in your services. What some of the controls are, thinking through some of the different operating environments that you work in. And so the way we've structured this is really just a bit of an open discussion. So the way it worked yesterday afternoon, which I think was really a good format, is that it quite quickly broke down into quite a good discussion for pretty much the second sort of, I could say 50, 60 minutes was just a good open discussion and lots of opportunities to ask questions. So anything that's not answered we'll then pick up with Q&As at the end. So I'll just move on to introductions. So I know some of you know me and Rebek already, but for those of you that don't, my name's Jay Rebek and I run Rebek. We're an Australian consultancy based in Sydney. and we focus on healthcare but obviously work with a range of other government agencies to support them on a range of issues. But most recently, over the last 18 months, we've been heavily involved with the Department of Community and Justice with regards to COVID-19 preparedness. And as Jag knows, so we did some work with out-of-home care to develop COVID-19 guidelines some months back, well, actually last year, and then some months back again, we refreshed it. And then we also did some guidelines for specialist homelessness services last year, which we again refreshed this year. And then this work is particularly focused on the COVID management plans and the components and the risk assessment that forms that. So that's me. That's a bit about Rebecca. So Mika, I might just get you to introduce yourself from our team.
Hi everyone, my name is Mika Kato. I'm a senior consultant with Rebecca, and I am a project consultant on this project. I helped to develop the guidance document, and I was in all the consultations with the peak bodies that we spoke to, asking questions about sort of the people that they serve or their providers serve, and the ways and the activities in which they serve these people, so that we could try and incorporate it into the guidance document to give all the providers some examples, some suggestions, some considerations on how they should manage their COVID risks. So it was nice working with them, and hope you find the guidance useful. Thanks.
Lovely, thank you for that, Mika. And Sophie, if you could introduce yourself and the DCJ team today.
Hi, thanks Jay and Mika. Yeah, look, Sophie Holloway, I'm the Director of Policy and Practice in Partnerships, and we've been working on the COVID-19 management and vaccination policy, and also been working with Jay and Justice Connect and Peaks to develop the resources and these sessions. So it's fantastic that everyone's here today. Good to see you here. I'm joined by a number of colleagues from my team. So Michelle Dowd is the Manager of Commissioning Policy and has been leading on this work. Joining Michelle is Leanne, a member of her team. There's also Jag Gorapati, who is from Child and Family, as many of you will know Jag, and I can see that there's a number from his team here as well. Catherine, two Catherines, and I think that's it for now, unless I've missed someone.
No, I think that's right. Lovely. Yeah. Thank you for that. And so, yeah, Daniel, great to have you with us. Lovely if you could introduce yourself as well.
Yeah, thanks, Jay, and nice to be on the call again. My name is Daniel Komisarov. I'm a lawyer at Justice Connect, which many of you might know is a registered charity and accredited community legal centre. I work in the not-for-profit law program of Justice Connect, which is a specialised legal program assisting the not-for-profit sector. And we've been doing lots of work on COVID-19 over the last 2 years. Some of you might have been joining our webinars. We've also produced resources. We've been invited by DCJ to join these training sessions to field any legal questions that come up. Of course, as a lawyer, I need to explain that I can't be providing advice on the fly, but I'll speak a little bit later in the training about how we might be able to provide that direct one-on-one advice to your organisations. But great to be with you.
Yeah, absolutely. And despite that caveat, Daniel, what I would say is in the previous discussions, we've been able to answer in general terms pretty much most of the questions that have come up anyway. So it's not been too restrictive, that slight caveat. So thank you, Daniel. Thanks for joining us. Okay, so Mika, if we just jump into...
Jay, it's Jag.
Yeah, hi, Jag.
Hi. So I just because we've got a smaller group, do you mind if we just do a quick kind of...
Yeah, let's go around the whole group.
Quick introductions, because there's a few names that I don't recognise, etc. So it would be good. It would be good maybe just to do some quick introductions as well.
Yeah, absolutely. And you know, I had the same thought a few minutes ago, and then I forgot to come back to it. So thank you, Jag. Yeah. So what I'll do is I'll go around and I'll just do a name call in order of how you've popped up on my screen. So Leanne, if you could, I think you've already been introduced by Sophie, but perhaps if we just go around the group.
Yeah, sure. Hi, I'm Leanne Flaherty, and I work in Michelle Dowd's team, and I'm a senior project officer in the team.
Lovely. And then Kim Cotton, lovely to have you with us.
Hi, can you hear me?
Yes, we can.
Yep, great. So my name's Kim. Obviously, I'm the HR coordinator for the William Campbell Foundation. So one of my roles is developing policy and procedure for the agency. Yeah.
Brilliant. Thank you for that, Kim. And Sharon Carter.
Hi everybody, I'm Sharon Carter, Veritas House. We're in Central West New South Wales and across the permanency support and youth homelessness sectors primarily.
Lovely. Thank you for that, Sharon, and welcome. Isabel.
Good morning, everyone. I'm Isabel Borg, Group Manager Governance at APSEC.
Fantastic. Welcome, Isabel.
Thank you.
Sabrine.
Hi everyone, sorry my camera doesn't appear to be working, but my name's Sabrine Mosley and I'm the Senior Manager, Governance and Risk at Morris 180.
Lovely, thank you Sabrine. And Catherine Brookard, I know you've been introduced, but perhaps say hi.
Hi, it's Catherine Brookard, so I work with Jag in the ITC.
Great, thanks Catherine. And we can just about hear you, but it's a bit echoey, so you may want to turn your volume up if you want to talk later.
There's building work going on here, so I'll keep myself muted, I think.
Yeah, sure. No, we can actually hear you. Okay, that's all good. Lovely. Okay, Miriam. Okay, I'll just keep going until Miriam. I'll just ask her to unmute and see if. Okay. Oh yeah, I can see you come off mute.
Yeah. I've got it. Oh, I'm Miriam Mangea. I'm the program manager for Mums and Kids Matter, which is a Wesley Mission service. We look after mums with a mental health diagnosis and their children at a residential service. So that's why I'm interested in this workshop today.
Yeah, fantastic. Yeah, well, thank you for joining us, Miriam. That's great. And Catherine White, I know you're in the DCJ team. Lovely if you could introduce yourself.
Yeah, hi everyone. My name's Catherine White. I work in the intensive supports commissioning team with JAG, so look after the ITC program.
Thank you, Catherine. And Jodie. I think we can hear you, Jodie. Can you hear us okay? Okay, I'll move on to Elizabeth O'Neill.
Hi, yeah, Elizabeth O'Neill. I'm the Executive Officer of a community organisation in the Sutherland Shire called Arana.
Lovely, thank you, Elizabeth. Welcome.
Thanks for doing that, Jay. Thanks, everyone. Just helpful to place where everyone's from. Thank you.
Couldn't agree more, Jag. Yeah, thank you for that suggestion. That's great. And Jodie, if you're able to introduce yourself, just jump in at any point. Okay, yeah, I can see your microphone's not working. No problem at all. We'll keep tracking. Okay, lovely. Okay, so the purpose of the guidance and this accompanying training is to equip DCJ providers who require support. Again, noting that some providers have very much got all these plans in place with the techniques, I guess, and the tools to develop a robust COVID-19 management plan, which includes a risk assessment. So pretty much the first thing that we wanted to say, and we've got some, if you've looked at the guidance, we tried to make this as clear as we can, is that the COVID-19 management plan isn't a thing in itself. It's made up of three constituent parts. So the first part of it is the COVID Safe Plan, which you can get from Service New South Wales websites. The second is the risk assessment. And the feedback that we've had from DCJ providers, it was very much that risk assessment, which is where some people were seeking additional guidance. So we've not developed anything new or different, but we've just consolidated some of the best practice guidance in this space to develop a good risk assessment template. And we've also gone through quite an extensive consultation process quite quickly over the last few weeks with all the peak bodies to get feedback on what some of the common risks and controls that service providers have been putting in place to actually, be as well prepared for COVID as possible. And then the third component is the business continuity plan. And again, we haven't actually specified in the guidance a template for the business continuity plan, but we have pointed people towards the business continuity plan that's provided by Small Business New South Wales, which provides a really good broad template that can be used. But just to reiterate, if you've got plans in place already, we're not asking you to redo those plans. It's very much for those organisations that are looking for additional support. And as per DCJ's COVID-19 management and vaccination policy, which came out in October, what DCJ are asking is for providers to have completed these plans by the 22nd of December. And now is a particularly good time to be doing that, because with borders opening, there are new risks. As I mentioned right up front, there is more virus being let into some communities that essentially, particularly in South Australia and some Aboriginal and Torres Strait Islander communities that actually haven't been exposed to COVID-19 in some cases at all. And now they are starting to be exposed. So with more virus circulating around, it's a good time to be updating these plans in any case. And we have been working closely with DCJ and the peaks to provide this, what we hope is quite simple and practical guidance. So the objective of today's session, threefold. Firstly, explaining at a high level how the guidance can be used to complete your COVID-19 management plan. Secondly, to apply the learnings from training to the real life examples of everyone who's on the call. And thirdly, to just provide an interactive forum to ask questions and share common experiences. So, we're really fortunate to have, Daniel, Sophie, Jag, and the rest of the team here. So really, whatever questions you've got, this is a really great forum to be asking them. And I'll just, I noticed, so we just did a round of introductions a few moments ago, but Rebecca, I see you've just joined us. It'd be great if you could introduce yourself to the group, and welcome aboard.
Yes, hi, thank you very much. So Rebecca, I'm CEO for Premier YouthWorks, so out of home care provider. So we've done a fair amount of work in this area, but just sort of wanted to jump in today just to make sure that we've sort of got everything that we need in place.
Great stuff. All right, thank you for that, Rebecca. Yeah, hopefully this provides a few extra bits of insights to bolster your plans.
Thanks, Jay.
Okay, so Mika, if I hand over to you, it'd be great if you could just talk through some of an overview of the guidance. And again, just noting that the actual guidance is available on the DCJ website and was published on Friday. Over to you.
Yep. So yeah, I'll just go through a brief overview of the guidance. So just to start off with thinking about scope of the guidance. So in terms of what the policy asks, so this guidance does apply to service providers who have been contracted to provide services on behalf of DCJ. However, as it says in the policy, it does not apply to those organisations who just received big grants from DCJ. This guidance, we do include, I think as Jay mentioned before, a risk assessment template, which is available on the DCJ website to download and use. We also direct you towards other existing templates that are available as examples from other organisations that they may have put those online and shared them for everybody else to have a look at. And we do share a bunch of other resources as well, which have come from some of the peak bodies, some other organisations, which are really helpful. And as Jay also mentioned, this guidance, it does not require providers to complete new plans if they've already been completed. So a large part of this is just to think about, what are the things that we need to update? Because as you know, sort of risk management is an ongoing cycle where you need to take into account any changes that might happen in the community in terms of legislation, in terms of the COVID environment, and think about how that might have an effect on your business and the people you serve. And finally, on this page, the guidance provides some considerations for common legal questions. And as Daniel introduced himself before, he'll be able to potentially answer some questions, but also outside of this session, he and his organisation are able to provide legal advice on a one-on-one basis, subject to some eligibility requirements. And yeah, this guidance does not provide specific legal advice because, as we know, all organisations are different and the services provided are different. So they might be too specific for us to address in the guidance. So moving on to the structure of the guidance itself. So you can see that we've got chapter 2 at the front, at the top of the page. And so that kind of goes into those 3 plans that Jay mentioned before. So those 3 plans, they make up the wider COVID management plan. And then the way that we've sort of formatted this guidance document is to sort of start off with that big picture, and then we move down into talking about specifics around the workers, the clients, the operating environments, and seeing how those factors feed into your plans, because any differences between providers for each of those 3 factors will affect the way you sort of manage your risks and your business continuity. So some of the examples around different workers might be the fact that they are full-time employees versus contractors versus volunteers, and how you should think about COVID risks and how you can consider controls around these types of workers. And then in terms of clients, there are some factors that affect different client groups differently. They might be living in a remote area or of a lower socioeconomic status, and you're obviously delivering to children and young people or families or people from cold communities. And so thinking about the ways that that might have an impact on risks. And then in terms of operating environments, we sort of go into the differences between face-to-face and things like residential accommodation or home visits or remote working environments as well. I think Jay will speak to this slide.
Thank you, Mika. Yeah, so in terms of the legal requirements, and as I sort of talked about before, Daniel can provide more detailed responses to any questions that you have. But as an overview, one of the key bits of legislation that is important for this work is the Work Health and Safety Act. And in terms of what that means is that because COVID-19 is foreseeable as a risk, it is important that providers have put in place mitigations to either eliminate or minimise risks to health and safety as far as reasonably practicable. And that's the key issue here. So one of the related concepts that we'll touch on later is the concept of the hierarchy of controls. And this really speaks to, in any given situation, we want to be able to try and put in place the most effective and highest level of control possible, but we recognise that you work in the real world, and the key control is obviously eliminating any face-to-face contact, and it's just not practical in given the nature of the services that you deliver. So what the hierarchy of controls teaches us is to sort of then work systematically down through that hierarchy of controls to find what is the highest level of control that is reasonably practicable for your service. And that means that your providers do need to be working around your risk cycle to identify, assess, and then minimising risks as much as you can. But in parallel with that, there's also a general duty for employers to consult with workers on all safety measures. So it's important that when you are particularly thinking about what measures you're going to put in place to control the risks that you've identified, that you are consulting with your staff around that. And clearly one of the hot topics around this space is around vaccination and around individuals' preferences around whether or not to get vaccinated. So in terms of what does reasonably practical actually mean? So it does talk about this highest level of protection given the circumstances, and it does take into account the type of risk, the degree of harm, understanding a bit more information about the risks, and really thinking about what types of responses you can put in place. Now, there is a range of other legislation that's in place, including public health orders, which clearly, as we know, are changing as we move to different stages of opening up. There's anti-discrimination, privacy considerations, and we had had lots of important discussions about that, particularly with things like domestic and family violence, about whether or not you might maybe wanted to share some of your information. Industrial relations, again, when we're thinking about some of the discussions that have in particular around vaccination policies, and then workplace law more broadly. So that's the reason why the legal picture is not straightforward, because there's a number of bits of legislation that need to be considered in a holistic way. Okay, so I'll hand back to you, Mika, if you could just talk us through some of the rest of the structure guidance.
Yeah, sure. So this is basically outlining what is required by the DCJ policy. So again, just to reiterate, if you do have these plans in place already, we're not asking you to change everything to align with the templates that we've provided or suggested. We're not asking you to redo them. It's just to make sure that you've sort of ticked off the things that we will talk about later on, particularly in terms of the risk assessment. And so we've got the 3 plans that we hope that you are able to develop or have already developed here. And then separate to that, the policy asks that you have this range of processes in place and sort of documented and communicated to your clients and to your workers. And likely that you already have these in place, for example, how to respond to a confirmed or suspected case of COVID in the workplace. So you should have that documented somewhere, what the steps are, who to get involved, who to talk to, and how you would respond to that situation. So just going through and checking that you have all of these updated and ready to go should something actually occur. So in terms of the first plan that the DCJ has asked that you have in place, which you should have already, is the COVID-19 safety plan. So that's from the New South Wales government website. And all you do is you go online, you select the industry that you work in and complete the safety plan using the online template. And you also have to register as a COVID safe business. So it's pretty simple, and it's very likely that you would have already completed this. You just need to keep a copy of your plan with you and provide it when you are asked for it. So that's pretty simple there. So I'll hand over to Jay for the risk assessment.
Lovely. Thank you very much for that, Mika. So yeah, what you'll see, what we try to do in this guidance, in all the work we try and do, is just try and simplify things so that, and so what we've done is we've really built the risk assessment template that we've provided around the 4-step risk assessment cycle. And so, the risk assessment cycle, it starts off with identifying the key hazards. And again, in the guidance, we provide lots of detail of some of the, and we've obviously previously just on the previous slide mentioned some of them, but identify the types of hazard, assess the risks in terms of likelihood of the risk, the severity, and then using a standard kind of risk matrix, which simply combines those 2 factors, that spits out a set of urgency factors. So it really just says which are the things that we actually have to act on right away and which are the things that we could act on slightly later. So the combination of severity and likelihood gives us that criticality of action. And then that helps us to think through what the control measures are that we're going to have in place. And then there's a whole range of different circumstances that would cause us to review and maintain the controls. So in the first instance, we should just be regularly reviewing and updating our risks, because if we live it, particularly given that it's such a fast and dynamic environment that we're operating in. But also there might just be things that happen, like now, given borders are starting to open, it's a really good time to be reviewing your risks and thinking about what the increased likelihood of COVID getting into some of your facilities or into your local communities. But also it could be, for example, if a new strain emerged, if public health orders were to change. So any kind of any sort of significant event like that. So as well as that sort of regular review of your risks, you need to be thinking about those sorts of events. So the other thing that we have suggested in the guidance, and I think this is really good, solid advice, is that we recognise that many of you will be operating in multiple different service settings. And so clearly the types of risks and controls that are appropriate are highly variable depending on the service setting that you operate in. So we do recommend that you do, and it's no more complicated than a separate row on the spreadsheet for each service setting that you operate in, to make sure that you have thought through those different risks and controls. So that's the high level risk assessment. So I'll just sort of step through each of these. So in terms of thinking through the identifying hazards, so on step one, so if you just head on to slide 16, Mika. Thank you. So we need to think about the activities. So that's all the tasks that are performed by workers in your service settings, including services that are performed for clients. And when we think about workers, the definition of a worker is quite broad. So we do need to actually think about all aspects. So that can be whether they're paid or unpaid. We still need to consider the risks. And in any capacity that they're working. So it could include employees, contractors, subcontractors, consultants, volunteers, students, and even the term student can include apprentices, trainees, even people on work experience. So in short, anybody that's coming into contact with the service, who's actually providing the service is, providing some kind of service is considered a worker. And then we need to think through the clients themselves. And again, in its broadest term, the term clients is really anyone that's coming through the service. So that could be a member of the public. Obviously, it's the individuals, the groups, children or young people who are actually either residing in your services or being provided services. And it really everyone who's comes into contact, say if they've got disabilities, if they're offenders, if it's families of young people, children, young people, for example, in out-of-home care settings, then all those people will need to be considered. And again, this all comes under that kind of work health and safety banner. We need to be considering all of those risks. So thank you, Mika. If you move on to the next. So again, in the guidance and the template, we've provided a matrix about how to consider the severity and likelihood. So once you've identified each of the individual risks, it really is as simple as assessing against these sort of 2 5-point scales what the severity of the risk, what the likelihood is. Now, clearly, with COVID, some of the risk ratings are going to be critical, because if we have got COVID outbreaks in our facility or in even our local communities, the severity is really serious. So it is an unusually high level of risk environment that we're dealing with COVID. So that's why this is all needs to be considered quite so carefully. But yeah, I think we just need to make sure that we've just rigorously work through these. And as I mentioned previously, recognizing that particularly the likelihood of the risk could vary quite quickly, depending on changes in the external environment, such as borders opening as they are at the moment. So thank you for that, Mika. I touched on this previously, but when we think about how we control risks, the hierarchy of controls is super helpful, framework to consider this. And so as I mentioned previously, what we want to be trying to do is always put in place the highest level of control that is practically is practicable in a particular situation. So the highest level of controls have the highest level of health and safety protection, but also they're the most reliable control measures to put in place. So at its highest level, as I touched on previously, if you can actually keep people physically apart, so physical distancing ultimately is the highest form of control. So if you can do that and it doesn't have any negative impact on service delivery, then that's where you should start. But clearly, it's not reasonably practicable for most of the services that are being delivered. So then you need to work down to the next, substitution, isolation, and engineering. Substitution, where we potentially might switch to a shared or single accommodation, from shared to single accommodation. So that gives an opportunity for particularly for any people in out-of-home care, for the children, young people, to potentially living a little bit apart. Isolation, physical separation. So if there's any way to segregate, have barriers, just structurally design the the architecture of the environment so that there's more physical separation. And then the third is really around process and mechanical devices. So that could include looking at your ventilation, your air conditioning, your heating, and thinking through what kind of appropriate filters might be in place, but also things like opening windows where that's possible. Some facilities it's not always possible. So just thinking through how you can get the appropriate airflow. And then as you work down, we then go through to some of the administrative and PPE. So things like QR codes, check-ins, I'm sure all of you will be completely across this. And again, PPE. So again, where we know that we are working people, particularly who have suspected or confirmed case of COVID, then making sure that we have got that sort of PPE. And then there's also things like hand sanitizers and all the good stuff that we know to work. So hopefully that gives you a bit of an overview of some of the key controls that you can put in place. And as I mentioned previously, this is really just a nice way of just thinking through what you need to be reviewing, both on a periodic basis and should circumstances change. So we do need to be thinking about, consulting with workers is an important one, because if situations are changing and let's say your risk's going up and you might decide to take a more robust view in terms of vaccination, for example, then you do need to be consulting with workers before you make those sorts of changes, making sure that your training's up to date, you've thought through how the hazards are changing. As we talked about for plant and equipment, so whether that's air conditioning or physical architecture of the design space, and really just the governance and the accountability that sits around health and safety. So it is important that you've got regular governance sitting around your risk assessment process and your controls. So if we look onto the next slide, again, as I mentioned earlier, what we're trying to do with the risk assessment template that we provided, and again, this is just a process diagram, which essentially each of these steps is a column in the spreadsheet that we provided, is just have a really kind of structured way of systematically working through the risk control cycle. So again, for most of you, this will be familiar. You will have filled out lots of risk assessment templates during your careers. But we start with the workplace setting. And as I mentioned previously, in a spreadsheet, we kind of got a separate row for each workplace setting. For each, we're going to have a separate assessment for each workplace setting. So for each setting, we're thinking through the tasks. So what does your service do? What are the operating environments in terms of how the service is delivered? Who's delivering the service and who's receiving the service? And based on those sort of four different perspectives, we then think about what the risk factors are. We think about how we are going to rate those risks, and then what controls are going to put in place to mitigate those risks, to mitigate or try and prevent those risks coming to fruition. But if the risks do materialise into issues, to try and minimise them wherever possible. And this will lead us to a clear action plan, which we will then be continuously reviewing in that sort of cyclical fashion that we previously discussed. So that flowchart is just a structured way of thinking through the risk assessment cycle. And so again, that's how the Excel's structured. Thank you, Mika. So, and then so that's as you will see with our guidance, again, based on the feedback we had, it really was that risk assessment template where providers were asking for most guidance. That's where a lot of the guidance in the guidance is provided. But the third key component, so if you really the risk assessment is where a lot of the thinking about your planning comes into place. And then the information from your risk assessment is then going to flow into your business continuity plan, and then it's going to flow into your COVID safe plan. So you do want to make sure that these three documents are kind of considered in parallel with one another. And as I mentioned previously, we recognise that there's lots of organisations that develop different business continuity plans, templates over time. That's fine. We're not asking you to change the template. So feel free to use the existing business continuity plans that you have. If you don't have a template in place, we point you towards the business continuity plan from the New South Wales Small Businesses website. which is a really good general plan. It does include COVID and a range of other business continuity risks, such as fires and flooding and so on. So it's broader than just COVID, which we see as a positive thing. Okay, so we wanted to acknowledge the great level of resources that are available across the sector and the great support that we've had across the sector in pulling this guidance together. So you can see all these peaks. We've had really good discussions, and Justice Connect as well have sort of provided input, and we've got really good guidance on the Justice Connect website that we've linked to from this guidance, which really just speaks to the urgency that the sector's seeing in putting things in place. So a range of other webinars, documents, facts sheets, seminars, guidance that's been made available across the sector. So again, we've tried really hard to try and incorporate the good thinking from those into our guidance. Now, I wanted to hand over to Daniel next to just talk us through the support that's available to providers from Justice Connect.
Yeah, thanks, Jay. As you've already sort of alluded to at that legal requirements slide, going through this risk assessment, you're likely to engage in a whole number of areas of law, being privacy or anti-discrimination laws. There's likely to be legal nuances specifically around being an out-of-home care provider. So our service, alongside sort of the free resources and webinars we provide, we also have a direct advice service where we field or take inquiries from community organisations specifically on a particular legal issue in relation to this process of assessing COVID-19 risk. We do have eligibility criteria attached to our legal advice service because we have allocated, limited resources ourselves. So we focus on, small to medium-sized community organisations that are servicing disadvantaged members of our community, and really those organisations that can't, attain their own paid legal advice. So if throughout this process of assessing your risk, you engage with a particular legal question, please remember our service and feel free to make an inquiry to us. Thanks, Jay.
Yeah, thank you for that, Daniel. That's great. And actually, this is a really good segue into our first opportunity for questions and answers. So we know we've had a whole range of questions that have come up on previous calls, ranging from things like, what if some workers don't want to get vaccinated? What if some service users don't want to get vaccinated? Can you get people, ask people to be tested before they come into service? There's a whole range of some of the issues that have come up in previous calls. So really just wanted to open the floor to any questions like that, or indeed completely other issues that you might have to put to the panel we've got here, really. And feel free to come off mute, feel free to put any questions into the chat. So I might just get the conversation going by asking a question, Daniel, because I know this is one that's come up quite a lot. So yeah, can you just talk us through some of those tricky issues about vaccination, both, if you've got either people entering the service who refuse to either disclose their status or get vaccinated?
Yeah, there's a lot to unpack when we talk about that, compulsory vaccination, and it's as has been set out in the guidance, there's a whole range of legal issues to think about for workers as well as service users. So I might just focus on service users because I think generally my impression is that the sector has become more familiar with some of the workers' issues. So for service users, when we think about mandatory vaccination, the starting point is there isn't a legal relationship to say you need to be vaccinated. You need to go and make an appointment now to be vaccinated. It's a work health and safety question. So if we go back to that slide when we think about our work health and safety obligations, all of your organisations related to COVID-19 or not, need to be thinking about how are we protecting all the people that interact with our service, volunteers, carers, young people, members of the public, contractors, employees. So as part of that process, the assessment is what's a reasonably practicable control measure. So that takes us to the question, would it be reasonably practicable to only allow service users who are vaccinated to access our services? For many of your organisations, you're working with a lot of young people who might even be under the age of 12 who can't be vaccinated right now, and that's not the government advice. So the answer probably to that question is no, it wouldn't be reasonably practicable to mandate every person coming into the organisation or interacting with the organisation to be vaccinated. So where that's the case, then the question becomes, well, what else can we do to ensure that we can provide services in a safe way? So that's potentially asking about where the service user has been in the last certain period. It goes to those work health and safety control measures that we've become familiar with, including, PPE. I've been on other calls where there's been questions about, providing services outdoors. And I think that's a really sort of pragmatic approach, all about those space quotients as well. So I think there's a lot to think about when we talk about service users, and DCJ as well has made it clear that we're not hoping to see service providers who are supporting those really disadvantaged communities to start retracting their services. That's not why they exist. That's not why they're funded. So it's just about managing their work health and safety risks where we mightn't be able to mandate vaccination.
Yeah, lovely. And Sophie, I know one of the questions we had on previous calls was whether DCJ, and there was one provider that asked whether DCJ was making vaccination mandatory for service providers. So I wonder if you could just pick up that question, Sophie.
So no, part of the process with the COVID-19 management and vaccination policy was that given service providers are separate entities, and based on Crown Solicitor's advice, our advice is based on work health and safety laws, and that the purpose of this is to undertake risk assessments for each provider based upon your own operating environments, the nature of the work that you do, and then make a decision about the best controls that you wish to use in those circumstances, of which vaccination is one. And certainly talking in some other forums, when we had some breakout sessions of these sessions with other cohorts, it was clear that some providers have chosen to make vaccination mandatory for staff, and others have deliberately chosen not to, and they're using a range of different controls, and that's exactly what we would be expecting. Certainly, I guess what we do say though is DCJ has done its own risk assessments, as we've indicated, and DCJ has made the decision that all staff at DCJ, regardless of whether they're frontline or in office-based work, have to be mandated. So that's what our agency has done, but each organisation makes its own decisions based upon, I guess, your operating environments and the work that you're doing.
Lovely, thank you for that, Sophie. Jag.
Oh, hi, Jay. I just wanted to, just sharing, I suppose, something that we heard recently from residential out-of-home care providers around managing unvaccinated visitors to a residential home. So there was a particularly kind of interesting policy question about unvaccinated birth parents and the department and facilitating family time for children and young people when birth parents were unvaccinated. So I just thought I'd raise that in case there was any sharing or discussion on that point.
Yeah, so Daniel, from a legal perspective, and then Sophie, I might get your take on it as well.
That's a really complex one, and I would encourage, if that is a particular organisation, to seek advice on that one, just because it's this interesting interaction potentially with family court orders in the context of work health and safety, in the context of this notified policy. So there's absolutely a more complex legal framework. I think generally speaking, though, unvaccinated birth parents might still fall under a category of people who are coming into the organisation or coming into the organisation's workplace, if that's sort of a separate premises. And those people should absolutely be considered in the organisation's risk assessment. They might determine that it is reasonably practicable to impose a requirement that birth parents be vaccinated in order to be around young people in the organisation's care. But of course, we'd need to think about how that interacts with court orders. So it's a complex one. Those are sort of my general comments.
Yeah, thank you, Daniel. Sophie.
Yeah, look, certainly from a DCJ perspective, our legal team, we, if you're looking at clients, in the same way that we can't mandate that a citizen as such, you must go and get vaccinated, we can't mandate the same for clients or visitors. I think the question here is about accessing a service, really, and whether that person can access a service in the same way. And I guess from our perspective at DCJ and JAG, I'd be interested to hear your thoughts too. You know, we're here to provide services to the most, and look, everyone on this call knows this, we're here to provide services to the most vulnerable people in the community, and we would like those services to continue. I guess that, you know, if some services decide to say we're not going to allow people to access a particular type of service because they're not vaccinated, you'd need to sort of, and I'm sure, Daniel, you would be able to sort of add to this too, you do need to be thinking about anti-discrimination issues. There's privacy that has to be taken into account with all of this as well. And then also there would need to be a discussion with DCJ and your contract manager, because, you know, we'd need to look at, does that have an impact on service provision and what that means? So they're the sorts of considerations there. But look, again, interestingly, I understand that there's lots of different ways that people and organisations have been working to manage the various kind of situations. And I guess just reflecting on the last 18 months, nearly 2 years now, we've all been doing it anyway. We've been managing where we've had risks to you know, to people who may become positive in the absence of a vaccination. So it's actually, you know, we've kind of been working out controls anyway. That's the sort of reflection that I've noticed in discussions with other providers and staff. Yeah.
Yeah, I suppose, yeah, just to add, I mean, obviously completely agree with everything Sophie said. Just to add about that specific scenario that I sort of raised about potentially unvaccinated birth family and family members and family contact and so on. We did, like, there was some really like interesting and positive sharing from service providers about how they're managing that from a practical perspective. You know, just things like encouraging family members and offering them support to get vaccinated in their phone conversations with family members. Encourage having policies to ensure that family visits were only occurring in open sort of outdoor spaces, whether or not they were vaccinated, and I think also potentially, you know, the use of social distancing and masks and so on, the sort of practical measures during supervised family contact visits, and also I think also, you know, things like requesting testing maybe of any unvaccinated family members prior to any family contact visits and so on. So just adding some of the, you know, it was a kind of what do they call it, a Dorothy Dixer maybe that I asked, because yeah. I sort of sat in this fascinating discussion with service providers at another meeting and just wanted to share some of that.
That's lovely, Jag, and I think that's triggered a really good question from Elizabeth as well. So Elizabeth's asking, so with a volunteer home visiting for vulnerable families, and while staff that enter the home are vaccinated, I think we'll struggle to find volunteers to go into people's homes where the parents are not vaccinated, and this may reduce our ability to provide service and therefore our overall contracted numbers. So yeah, Elizabeth, it'd be good if you could just perhaps expand on that point.
Yeah, so can you hear me?
Yes, we can. You can hit fine.
So under TEI, we're contracted for, it's called early support. So vulnerable families are referred often by the early childhood nurses. It's for families with children 0 to 3 where they might be multiple birth or child or parent with a disability or postnatal depression, whatever it might be, and that they haven't got any other support network. So we have trained volunteers that we then, once we go, the staff go into the home and do, generally anyway, the risk assessment and just make sure that the family is eligible and meets our criteria and all the rest of it. We then match that family with a volunteer, trained volunteer, who stays with that family for up to 12 months, visiting each week, just supporting the mum in her parenting and in her whatever she needs, basically. Not cleaning, not that sort of thing, but her parenting and her, I guess, attachment and just general level of frustration when you might have a couple of toddlers and a baby. So we've already had some volunteers say, you know, if the family isn't vaccinated, I don't want to be going in. I don't want to be matched with any families that aren't vaccinated. So while the staff are happy and will go and do the assessment, I think we're really going to struggle if we do have any families that aren't vaccinated to find a volunteer that's willing to be going in and staying with them for up to 12 months.
Daniel.
Yeah, sure. Thanks, Elizabeth. That's such a complex question. I think there's sort of, my mind goes to a few legal issues, but I think the starting position for me goes to sort of that consultation piece. I find that organisations sometimes are more successful in bringing their volunteers along the managing vaccination process where they're quite closely engaged in the process, not at all implying that you haven't done that, just general comments. So where we hear from our volunteers, what do you think what are you most concerned about? What would make you feel that you can carry on your volunteering in the safest way possible? So in continuation of all our work health and safety assessments, we'd think about how we can support that service delivery with a volunteer in the safest way possible. So ultimately, however, it might just be that a volunteer says, even with asking the family their vaccination status, even if the service delivery was outside, the volunteer might still feel uncomfortable about performing that role. The difficulty where we have volunteers performing those essential functions is that the nature of the volunteering relationship is that they can walk away at any time. That's unfortunately sort of the risk for a community organisation that really relies on those essential service volunteers. So at that point, that's probably where we need to speak to our funding partners about, you know, missing KPI requirements while we're in this transition phase where the organisation might need to be looking at substituting volunteers performing that function with employees, for example.
Yeah, that would be near impossible on the funding, because we see approximately 60 families a year at 3 to 4 hours a week. So yeah, it's a lot of volunteer hours. All right, there's something to think about.
Thanks for that, Elizabeth. Now, I see, Miriam, you've come off mute, and I was just wondering if you had a question or...
No, not at the moment. I sort of attended yesterday's meeting as well because our program crosses over. Yep. So I got a few questions answered from yesterday.
Lovely, thanks for that. I think, Sharon, I saw you pop off mute a moment ago. I was just checking if you had a question.
I did have a question, and I've typed it into the chat room. It's primarily for Daniel. One of our peaks has told us that they've received and shared with us legal advice regarding the coverage of the public health order for disability and care workers, with particular potential impact on PSP or ITC, ICM, homelessness providers, etc. So pretty much all of the people attending our webinars. And that is that workers in these settings are often working with children and young people who do have a disability. And because our public health order doesn't define disability, the interpretation is its disability is a general anti-discrimination definition. And it doesn't define workers in this area as particularly being disability workers, but as anyone providing a service to a person with a disability. And that therefore people within our area should be compliant with that public health order. That's something that I don't think any organisation has pulled the trigger on yet, because it's something that if one organisation follows that and it's agreed, it suddenly impacts on the entire sector. And it has the potential to put us all in breach of that order, if that is the case. And if it's not the case, then we go back to doing exactly what we're doing now. I'm trying very hard to find different pieces of advice on this particular matter, and every time I've spoken to anyone in a legal setting, they've given me a different answer. So we're all spinning around a bit in circles on this one.
And
I was
Daniel,
wondering if Daniel had a comment.
yeah, Daniel, just before you comment, it'd be good, Sharon, just for clarification, when you say that most of our organisations are now in breach of the public health order, just because
That could be if this applies.
In what respect would they be in breach?
All workers in this sector would have to be double vaccinated by the 26th of November. Otherwise, they would not be allowed to work with clients.
Yeah, thank you. Daniel, over to you.
Thanks for the question, Sharon. And this was actually...
Sorry, Daniel.
No, that's okay. It was actually just brought to our attention, this amendment to the public health order just this morning. So I haven't actually had time to look at what it means. I'm aware of that advice that was sought. I think I'll reserve landing too quickly on what it means for the sector. Best case scenario is also that many of the organisations in this sector are already requiring double vaccination, regardless of whether the public health order applied or not. So hopefully, you know, in a really pragmatic way, this isn't actually affecting huge numbers of workers. But I think this is something that might be worth sort of looking at and getting that advice on. Particularly, I know if one provider gets the advice, it's going to get passed around. So it might be most effective to work with the peak and just get consistent advice for all providers. So Sharon, maybe we'll chat further offline, unless Sophie, did you want to?
Yeah, I'm happy. We've also received advice from our legal team this morning on this very issue as well, that there's been the original order has been repealed and replaced, and it applies to disability services workers, whereas the repealed order applied more generally to a person who provides disability services. So, I mean, I've got the sort of language in front of me right now, but I think what we'll need to do is seek further advice from our legal area, and we're updating our FAQs, and I think Michelle's still on this line, and Leanne, I can see you there too. We're updating our FAQs, but I might actually go and seek advice from health as well on this particular one through our state emergency operations teams, so that we can be very clear about what it means, and just sort of get back to everyone, and we'll update our FAQs and advice as needed post this. It's probably the best way of doing it, but just wanted to flag that we've also been provided with advice about this morning from our legal team, but I'd like to sort of look into it further and really give a clear answer to you all.
Fantastic. No, that's great. Brilliant question, Sharon. Thanks, Daniel and Sophie. So yeah, sounds like this particular issue is hot off the press. And Sophie, thanks for offering to come back to the group on that. So yeah, any other key questions at this point? That's been a really good set of questions. There's I'll just move on in that case. We've got plenty of opportunity for further discussion. So we found this next section quite informative in previous meetings. So we just wanted to sort of talk about some of the key risks and key controls for workers and clients in your settings. And so, look, some of the key risks, the key areas that create risk. Now, obviously, the type of work that workers are actually delivering is really important. So whether they're actually residing, residential out of home care, that's very different to if they're working delivering coffee in a coffee van, as some of the other community providers in our sessions yesterday provide. Vaccination status clearly is a massive risk factor. I think the interesting thing about vaccination is it both reduces your chance of ending up in hospital if you're vaccinated, but it also more than halves your chance of actually catching the disease in the first place, which was actually never really expected from vaccination. So the fact it's quite as effective as it is at preventing infection is something that's really impressive out of the research that's been done and out of the vaccinations that have been developed. But again, once the problem with that is because it's still only about 50% or so effective, you do need to get to that herd immunity effect. So really up in the 90s, 90%, before the kind of compounding effect of vaccination really kicks in, which is why we're seeing, so for example, Austria's just had to move into a lockdown the last few days, because I think they're only up into like in the 60s in terms of percentage of vaccination. So any of our communities that are still 60s, 70s, 80s in terms of vaccinations, there's every chance that they could have resurgence of COVID. You really do need to get up into the 90s before you can start really seeing the effects of herd immunity. And so I think obviously vulnerable populations, so children, young people, if you've got people who are immunocompromised, who've had any childhood diseases, if you're dealing with it's just children and families, but if you've got any sort of grandparents coming to visit or anything like that, so obviously particularly Aboriginal and Torres Strait Islander people typically have higher risk factors because of the accelerated aging effect. So people in their 60s are considered elders in Aboriginal and Torres Strait Islander communities. The other really important thing to think about is the extent of community transmission. So I think it's really important for you all to be constantly vigilant and paying attention and checking on a regular basis about what's happening about COVID in your communities. Because obviously, the minute you've actually got an outbreak in your local community, all of a sudden, as I say, the severity of the risks isn't going to change, but the likelihood suddenly goes up. So you may want to be assessing that. And again, means of travel. So the way that people are actually traveling, either coming to and from your facilities, whether they're doing it on public transport, with their ride sharing, in their own cars. And as everyone will remember from the early outbreaks that happened last year, when we had a number of people who work across multiple different locations, particularly residential aged care. That was one of the ways that it was really shuttling COVID around different sites. So again, I know that's not such a problem, but it's still something to really think about carefully. So some of the controls to consider. We talked about vaccination is. Everyone talks a lot about it, but it is one of the highest order on the hierarchy of controls. It's one of the highest ones. I think communication about vaccines is really important, because I think what we've found increasingly as we get to higher vaccination rates is you find a lot of people were just a bit hesitant to get vaccinated, but once better communication and also better role modelling has been happening in the community, then you are seeing, increasing levels. I was listening to Pat Turner from Nacho on the radio on Friday morning, and she was saying in Aboriginal and Torres Strait Islander communities, there's been a lot of misinformation around vaccines, particularly that's coming into Aboriginal and Torres Strait Islander communities from America. And in some particularly religious communities like Pentecostal areas, religions, that's actually been a potential source of misinformation. So it's just you need really close engagement with those particular community leaders to try and get really good communication. And then there's a range of other specific controls. such as training, rostering, staggered rostering, thinking through the mental health and well-being aspects, making sure that you're protecting vulnerable workers, and then a lot of client-specific information. So we had a really good top tip came out of our call yesterday, actually, which was that something that actually I only learned through discussion, that if you go into your New South Wales app on your COVID app on your phone, that's actually the where you'll get notified if you're a close contact. And often, where particularly as volumes of COVID get higher, you may not actually get a call from the public health unit. It may literally just come up through your app. So well worth remembering to have a look on your COVID app and see if you have been registered or pinged as a close contact, and indeed let other people who are working or using the services about that is a place that they might find out whether they're a contact. And then finally, intake forms and things like that. So there's a range of really useful controls. If we move on to the next slides, we're conscious in out-of-home care that you've got a whole range of client groups with specific issues. You've got obviously children, families, sometimes people who've experienced or risk of domestic and of family violence. So there's a number of specific issues, and then some of the other considerations that we've listed on the right there, such as previous trauma. So it's a whole range of things to think through. Now, we are putting all that stuff out there. Next, I'm just want to put a question out to everyone. Hopefully, that's sort of given a bit of food for thought in this. We recognise that you have been managing very well managing COVID for the best part of 2 years. So when you're thinking about your workers and clients, for you, what are the top risks that you see for your workers and clients, and which controls have been most effective? So we've, again, found this a really good conversation to start in terms of sharing good practice as well. So yeah, we'd just love to hear some of your experiences, how you've been traveling through COVID, and what some of the lessons learned on the way. So I'd love to hear if anyone could share some experiences. I'm going to have to start picking on people if nobody volunteers. Okay, so all right, Sharon, I reckon you've got some good experiences you can share with us.
Is that only because I can't lock off my video?
Yeah, exactly. It's a bit like sitting in the front row at a stand-up comedy.
Look, we've been pretty lucky, and we're also in a position where we've only got 3 workers that we're aware of who aren't vaccinated. So our biggest issue has been potentially what would happen if an unvaccinated worker was working with an unvaccinated service user. We will never discriminate against providing a service to a service user. That is what we exist for. So our biggest way of controlling that has been to isolate unvaccinated workers from working with service users. That is a very short-term strategy, and it's not a practicable strategy going forward. Our number one strategy for those workers, those 3 workers, are all people who are client-facing, so they're not working in a finance role or a people and culture role or somewhere where they could work from home. Will be to formally ask them to go through a vaccination process. And then go through whatever the results of that are. So our number one risk is unvaccinated workers working with unvaccinated clients. A second one is not knowing the vaccination status of people who are referred into our service, and therefore having to risk manage at the highest level because we don't know, and we want to make sure that we keep people safe and that we continue to deliver our services. Another one is that we offer services across a whole range of different areas and across a number of different geographic locations. So being able to separate our workers out and our teams out so that we tag team people into working in the office or working from a different location. So if, for example, one of our locations were to become a positive COVID site, the other locations can continue to deliver all of our services without a break in the continuity of service delivery. And that puts a strain on our organisation, but it served us well for 2 years, and we'll continue with that process until we're sure that we've got our vaccination coverage in place.
Sharon, that's a brilliant set of controls you've got in place there. Thank you for sharing. I think that has certainly come up. One of the issues that came up yesterday that you mentioned, which is, essentially treating people with the controls as if they have got COVID and until you're able to ascertain that they don't, which is obviously a very sort of pragmatic and sensible approach to take.
The area in which we work, every school in the town that I'm in, which is Bathurst, has had at least 1 or 2 days of lockdown since the beginning of November as a result of positive cases. And the kids that are in our remit are in all of those schools. So we're kind of rolling with it. Now, it's more difficult for us to operate and continue to operate than it was the first round of lockdowns and the first round of easing of restrictions, because now we know that there's a whole bunch of people who are moving around in the communities, which is wonderful, but it creates more risks for an organisation.
Yeah, that level of mobility, clearly, and Jodie's made a really good comment on a similar theme. So Jodie was saying that they've had a number of COVID positive staff in Jodie's organisation, however, no transmission to others, which she attributes to disability workers requiring to be fully vaccinated and wearing surgical masks while supporting customers. Biggest risks are staff working for other providers, particularly in sectors with high numbers of COVID positive customers, i.e. aged care facilities. So Jodie, would love to hear you talk a bit more about that.
I think Jodie's microphone wasn't working.
From earlier, that's right. Yes. So thank you, Mika, and thank you, Jodie, for sharing that online. Yeah, I can see. Yeah, so still not working, Jodie, but thank you for sharing that. And again, has anyone on the call had any? Well, what sort of controls have people put in place where you do have staff that are working with other providers in other sectors? Be interested to hear other people have tackled that problem. All right, so it sounds like that's a bit of a knotty challenge. Any other? So, Leanne, what experiences has your organisation had, and what in terms of have you had any other controls that you've put in place, or other risks that have emerged?
Well, I work in DPC, and we've all been required to be fully vaccinated. So that's the main control that's been put in place, and I continue to work from home.
Yep, no, that certainly works. Melanie?
Yeah, I'll jump in. So I'm from Life Without Barriers, and one of the things we've done here in New South Wales and Victoria is introduce what we call increased risk PPE. So where we might have in our ITC homes, where we might have children and young people who are, going out into the community and coming back to the home and potentially, potentially exposing our staff because they might be considered a close contact. We're asking our staff members to step into the increased risk PPE. And basically it's exactly the same as positive PPE or full PPE. It's just that the gown that's worn is slightly thinner than the positive PPE, and it's just meant that it's been a more affordable alternative to stock at the volume that we've needed to stock across our houses. So across Victoria and New South Wales, we've pretty much had a mandate that people need to be, when the situation calls for the higher risk, our staff need to be in the positive PPE. So that's the N95 mask, the face shield, the gloves, and the thinner gown. And along with people getting, vaccinated, those two measures, we've really seen less of an impact on our operations. And it's meant that, when staff come off shift, if they're in that increased PPE, they're not considered a close contact and they're just able to, return home after their shifts. So it's meant that we haven't had to do too much, rostering of staff because they're considered, close contacts. It's reduced the impact on our operations.
Yeah, lovely. Thank you for sharing that, Melanie. That sounds like a really, really good approach as well. And the other thing I know to sort of come up on some of the previous calls was around rapid antigen testing. So I know that was something that a number of people were starting to inquire about. And I know that this is an area, Sophie, that's currently being kind of explored. And I wondered perhaps if you've got any comments about that, because I know a number of providers have been inquiring about that.
Me, you want me to?
Yeah, Sophie, yeah, that'd be lovely, thanks.
So, look, we're working on a rapid antigen testing framework as to when it might be an area to stand it up versus not stand it up. What we know from health at the moment is that where there's low prevalence, the cost benefit of RAT is not necessarily playing out in terms of the problem that the business needs to have solved. But what we are doing at the moment is looking into, and we've been speaking to the peak organisations about this, is looking at a pilot where we can work out how it might be used and to test, what works and what doesn't work, and provide advice in that respect. So that's a sort of a work in progress, but sort of keen to hear anyone's thoughts about that. If not at this session, even if you wanted to contact us through the partner support or me directly, if you have my contact details. Very keen to sort of hear about what might, what you're thinking in that space and what might be helpful versus not helpful, because we're kind of sort of trying to sort of flesh out that literally as we speak. Yeah.
Any comments or reflections from the group? Jodie? Oh, no, sorry, so Jodie's still not me. The other comment I would make, just from our experience in rapid antigen testing, is that it's cheaper, it's easier to do on a proactive fashion, so it's potentially something you can do for all your staff. However, the accuracy is a bit lower than PCR testing. So exactly as Sophie was saying, where you've got very low prevalence of COVID in your community, and particularly low prevalence, high vaccination rates, then cost benefit may not be great. If you've got an area that maybe your vaccination rates aren't in the 90s, if they're a bit lower, and you actually potentially have an outbreak, it could be a useful tool in terms of potentially keeping a service running by actually using it as a bit of an early detection advice. Because whilst individually there's a relatively low actually in rapid antigen testing, once you take the aggregate effect of actually doing it on a repeated basis, say either daily or several times a week across a whole workforce, the fact that you've got a bit of inaccuracy irons out just in the sort of sheer weight of numbers. So it can be, as I say, if you've got lower vaccination rates, higher prevalence of COVID, I think that would typically be the sort of place where you might find it to be more useful. Great. Okay. So we've just got I think just a few minutes before we wrap up. So I guess really just wanted to give everyone an opportunity to ask any sort of final questions. The only other, I guess, thought starter that we had one more question from our perspective. Oh, Elizabeth, yeah, jump in.
Hi, so I put in the chat, but I'm happy to say it. So for unvaccinated workers, is it okay to say to have it in your risk assessment that they need to buy their own rapid antigen test and have a negative result each week before coming in?
So legally, Daniel?
The legal position would be probably not. Ordinarily, if an employer imposed sort of a safety obligation on staff, they would be responsible for funding it. So I think I would be surprised if we're seeing sort of that model being used where staff are required to pay for their own rapid antigen test and provide a negative result. I think that would be quite unconventional.
So even if they're kind of saying, no, I don't, if that's one of the things to keep, okay, we haven't mandated it. I don't know what to do. I really don't.
Yeah, absolutely, Elizabeth. And I think it sounds like it would be really beneficial to maybe we can get lots of information about your organisation and provide that really tailored advice to you. Okay. Because sometimes I think no matter what control measures an organisation puts in place, they ultimately arrive at the question of we might just need advice about disciplining employees who are not complying with the organisational policies. It's an unfortunate situation, but sometimes we it's an unavoidable one. I think where we get into the weeds, where it's about sort of who's paying for ongoing safety measures. If you'd like to, please feel free to make an inquiry for us to canvass all of these options.
Daniel, what's the best way for putting you in touch with Elizabeth, or Elizabeth getting in touch with you?
Yeah, I'll drop the link to our inquiry page.
Lovely, yeah.
In the chat.
Thank you.
Lovely, and then thank you, Daniel. Yes, that's been put in the chat group there as well. Lovely. All right. Well, I'm just conscious we're pretty much out of time, so I might just take the final opportunity to see if there's any further questions. Really appreciate it. It's been a really good interactive discussion, lots of debates through the meeting. But yeah, just last opportunity to, if there's any final questions, and if not, we'll wrap up the session. Okay. All right. Well, in which case, I'd just, I'd like to say a huge thank you for everyone that's attended today. Really, like I said, really good participation. Hope it's been useful for you. We're certainly learning a lot more about the questions that come out. Thank you, Leanne, for that. I'd like to say, yes, a huge thanks to Mika from Rebec, Daniel from Justice Connect, Sophie from DCJ, and the rest of the DCJ team that have been on hand. And thank you to everyone that's joined. So we just good luck, really. Good luck, everyone, with your risk assessments. Really, really good luck, and I hope that you're able to keep COVID out of your facilities and your communities, and keep safe, really. So and Sophie, I'll just hand over to you to wrap up the session.
Thanks, Jay. Thanks, Jay and Daniel and Mika again for a great session. And thank you everyone for participating and for particularly sort of having the active discussion. I think that is, it's one of been the most useful, I think, and certainly insightful parts of all the sessions. Thanks very much for participating. Good luck. And any questions, please send them through to the partner support email. Have a look at the resource pages on our website. We're regularly updating them, and this session will also be available to you shortly as well. And thanks very much again, Jay.
Thank you, Sophie. Thanks, everyone. Have a great day. Good luck, everyone. Bye now.
Thank you.